Hello all, welcome back to this course on precision oncology. Today we will be talking about cancer detection method part 2. In the last class we have really got introduced to what exactly is cancer screening, why would we really definitely, what is the point, what is basically cancer screening. If you recollect, we will say that we are just stratifying populations into positive and negative. We have taken example of cervical cancer screening and we have discussed about what we have just got introduced to the small concepts of what exactly is that lead bias, all the small terminologies pertaining to cancer screening. And then we further slowly went on to introduce about two small the word called the biomarkers there. We didn't go into details. Then we know what exactly is a positive predictive value, what is a false positive, what is a negative predictive value, and so on and forth. So today we will be in depth going into the concepts of a particular detection methods, what exactly they are, and what in this particular module we will try our best to cover all the existing detection methods for cancer screening, and we will discuss about the case studies for some certain cancer types like your breast cancer, your cervical cancer and the colorectal cancer, and importantly the lung cancer. Why exactly do we need cancer detection or screening? It's not exactly you say yes, no, cancer is not over. In fact, as I always been mentioning in this particular series, like it's a precision, it is more tailored. It is not like the cancer treatment regimen is tailored to fit that particular tumor type, this tumor type pertaining with the genotype. What exactly is the mutation? If a mutation is positive, the druggable genome is the druggable whatever is called, the target drug is different. That way, for different cancers, for your lung there is a TKI inhibitors. If it is an EGFR positive, the regimen is different for a EGFR wild type. Similarly with other cancer, for even your breast and others. Now coming back, this importance of cancer, it's not like it is started with Hippocrates. It is what he first said is that it is far more important to know that a sort of a person the disease has than what sort of the disease the person has. So basically the patients are stratified based on the particular cancer subtype, based on the genotype or what exactly the mutation the cancer is having. The cancer screening was an element of the periodic physical examination before. In the 1920s, it may usually consist of palpation to find a mass or maybe sometimes enlarged lymph nodes, and then or maybe an abnormal sound. But today what is happening? Screening has grown to include you have first definitely those age old methods are the visible methods, but definitely you have your radiological testing, then you have your measurement of your serum markers, and definitely a must is your molecular testing. If it is any of these is a positive test, it requires further diagnostic steps which may lead to further down you narrow down on the cancer screening time. Precision medicine, this is all your textbook material, has a long list of predecessor terms which similar meanings, which also includes your personalized medicine, predictive, preventive, participatory and medicine, which also includes your genomics medicine, predictive medicine and individualized medicine. As I mentioned before, the cancer goal of this cancer screening is to prevent death and suffering from the disease, that whatever the disease, that you have an early therapeutic intervention. The therapy will be started early to give a better treatment outcome. So, cancer screening usually refers to performing a test or examination on an asymptomatic individual who may seem healthy, but they could be harboring the disease in a very much in initial stages. What are this criteria to be met for your screening to be efficient? The disease burden is significant. For example, yes, there is a high disease. For example, your breast cancer or your lung cancer, the disease burden is very, very high. So the natural history of the disease is such that a detectable preclinical stage exists. For example, your cervical cancer. This progression is such that yes, if you can screen it in your preclinical stages, yes, it is very much treatable. Yes, the disease outcome is where the patient survival outcome is very, very good. Definitely, the course of the disease is such that your detectable preclinical phase is very, very favorable. If you detect it early, yes, the chance of survival are very high. The test or procedure must detect cancers earlier, as I mentioned before, if the cancers are detected much before the development of your symptoms, and your treatment should be initiated earlier. As a consequences, as a result, it will have a better clinical outcome. Now coming back to our favorable terms. A cancer, what is a biomarker? This is something which has been very well explored, this term. It's not necessary pertaining to biomarker, even but you have a biomarker for your heart disease, biomarkers for your diabetes. You have several biomarkers, so name it for everything. There is it's such a favorable term. I mean, it's a fantastic term in biology. It is a characteristic that is measured as an indicator or with pertaining to cancer, as a risk of cancer or occurrence of cancer. Anything which this particular marker is associated with the indicator for all these three particular instances, for example, risk, occurrence and patient outcome. These characteristics can be either, your biomarker can be either a molecular, it could be a cellular, or it could be even your physiological. For example, the size of the tumor can be not included as a biomarker. Yes. Now, this particular biomarkers are found in tissues or body fluids and are produced by cancer cells or normal cells in response to cancer. This is all your typical biomarker definitions. From your National Cancer Institute, it says that a biomarker is found in blood or other body fluids or tissue that is in signs of a normal or an abnormal process. For example, your HPV-16 in your cervical scrapes. Yes, it is. It is found even in both. I mean, it's not necessary it should be found, but you look for the presence of your HPV virus in your cervical sprains. That is called a biomarker. It may be used how well the body responds to the treatment. For example, your different biomarkers in the serum for a disease or a condition. So several dictionaries have this particular definition. Now, what is this role in a diagnostic? The role of a biomarker is to help diagnose cancer perhaps before it is detectable by conventional methods, as I mentioned before. In prognosis, to forecast how aggressive the disease process and or how a patient can expect to fare in the absence of a therapy. We have particular predictive to help identify which patients will respond to which drugs. These are all, the whole concept of biomarkers, especially to pertaining to cancer, is slowly evolving into all these three, this particular descriptions, and they all have this particular difference. For example, you have an miRNA panel, then you stratify a group of miRNA, then can you put them into one of this particular categories? Yes, very well done. This is the typical Cancer Institute which defines something a biomarker versus your clinical. Are they clinical endpoints? To define that, the National Cancer Institute defines a tumor marker, where it says a substance that may be found in tumor or tissue or which is released from the tumor into the blood. So, you assay for this particular biomarker either in the blood or directly from the tissue or into any other body fluid, for example, your urine samples. However, this definition is a very proper, which is given by the National Cancer Institute. Now, what are the different uses of your biomarkers? First thing, to check, as I said, mentioned, to response to treatment. Then your screening, very important, like I mentioned, your HPV virus. So, can we do that? Then differential diagnosis. Might be used for, yes, monitoring and progression of disease. Yes, can you use it for a risk assessment? Yes, you have different biomarkers, which we can really, as we go towards the end of this session, we will really understand how we can totally categorize the particular biomarkers. So, you have something what is called circulating tumor markers and tumor tissue markers. This circulating tumor markers are which are released into the blood. For example, your different DNA markers. Then the tumor tissue markers, which are ideally present in the tumor tissue per se. A tumor marker is anything present which is present in or produced by cancer cells or other cells of the body in response to cancer or to certain benign non-cancerous conditions. So, they have been usually many of these markers traditionally been proteins or any other substances that are made at higher amounts by cancer cells than normal cells. It can be found in, as I mentioned before, blood, stool, or they are found in tissues, body fluids with cancer. For example, many tumor markers have been characterized and they are in clinical use. Sometimes you only have one tumor marker which is associated with only one cancer, whereas you may have the same tumor marker even present to across different several cancer types. This is the typical algorithm for what is the use of biomarkers in your cancer medicine is like, for example, prior to cancer, can this risk assessment, as I mentioned before, is the patient at increased risk for cancer? Diagnosis, is this biomarker, is it useful? If you have a particular protein, whatever it is like, is it useful for diagnosis? Yes. Do I have a cancer? What type of cancer do I have? For example, this is here your classic examples of your breast cancer markers, that is your HR, PR, and DR markers. Then after diagnosis, cancer diagnosis, prognosis, what is expected course of the cancer? For example, you have a certain set of genes where definitely the outcome for if the patient is positive for this particular set of genes, yes, the outcome may be very poor. They may progress very, their prognosis will be poor. Then can you predict response? Then you have a set of genes, and then if you are giving them a targeted therapy, now will this cancer respond to this particular drug? Yes. Can we use this biomarkers over here? Yes. Importantly, again we can use a pharmacokinetics. Should they receive the normal dose or should they use a higher dose? And then monitoring treatment response. How is this cancer responding to this particular given treatment? Now again, post treatment, yes, you have several biomarkers where, okay, if you give, there is a recurrence, will this be, suppose this particular patient is positive for a certain set of genes, especially in your leukemia and all this hematological cancers, yes, there is like, if they are positive, yes, there is a very high chance of relapse or recurrence. Now coming back to your examples. So now you have there are several tissue markers, tumor markers in these tissues. For example, this there are many like your squamous cell carcinoma antigen for your esophageal cancer, and the CA for your colorectal cancer. This is this is mostly used for detecting your esophageal cancers, but it may have a little pathological significance. For the gastric cancer, the presence of this particular markers could be a little bit may not be very specific, but they are useful for the preoperative prediction of the progression state and pro-obstructive follow-up, post-operative follow-up, as I was mentioning before. That is like CA 125, 125A is now here, it is used for predicting peritoneal dissemination. Then CA19, AFP are useful for predicting liver mets, metastasis for liver. For the colorectal cancer, CA is useful to diagnosing its presence. It could even predict your progression and for performing follow-up. Thus, tumor markers with for high specificity for your hepatocellular carcinoma, it include your AFP and your and protein produced by the vitamin K, that is your PIVK 2. AFP is a representative of your carcinoembryonic antigen, that is your CEA, and it is normal in produced in fetal liver and fetal liver, but if it is not produced after birth. You have the different particular markers here associated with different cancer. For example, this particular neuroblastoma, you have the NSC. So, we really know now that there are several tumor specific markers. For example, your prostate cancer has your PSA here. This is all very much onto the tumor specific markers in the particular tissues. Something very important here which we will have to be discussing when you say a cancer screening or cancer monitoring or cancer detection, whatever, is something called imaging. Now this is a simple algorithm. Now before this is now, it's like, as I've been mentioned, the traditional methods for cancer detection maybe could be imaging or whatever, maybe, which are not still sophisticated. But again, when you develop a molecular signature for each patient type, now how do you combine the cancer for this whole algorithm to give the benefit for a better outcome for the disease? This, like, this is one of the biomedical imaging. This is a very strong pillars for comprehensive cancer care. I am not putting images for, because it's like all PET CT, everyone, all of us are now familiar with those instruments, and it has many of these images. Now they have real time monitoring and a single till and up to the level of a single cell specificity, and then they, even without harming the other host tissues, without they are able to, we are really having high and sophisticated biomedical imaging techniques now. The time scales for all these machines go from milliseconds, and they even go for protein binding and chemical small chemical reactions. The size scale also go from molecular to level to cellular to organ and again to the whole body scan. And it's based on the whole. This is like usually the imaging is the central role of imaging in cancer management is for screening the symptomatic or the asymptomatic people and for better disease management. So it is like the screening, then here you may recollect we were talking about diagnostics and staging. We talked about the different stages of the different cancer. Then again for the during the treatment and monitoring, again, yes, the imaging is adapted. Then for follow up also, yes, every suppose a patient is with breast cancer, after they have finished their treatment and after they are, every 6 months you need to go back to the hospital, to the cancer institutes or to the hospital for a better follow ups. The one thing is, like, majority of the imaging, it's not sometimes, not very non-specific markers. It's like, it's like, for example, your PET CT. Then you even have your imaging, the mammography, the colonography, then the endoscopy, the cath labs. Molecular imaging has played a very important role in the lab for biomarker discovery. And it's like, now it's like through today's imaging technology, we are able to show exactly the location of the tumor. Then imaging systems are constantly evolving, they are evolving, and they are allowing the scientists to explore the smaller components of the body very much in a larger detail. At the level of this is how this is how the physicians allowed the techniques allowed the physician to see in the body. At the macroscopic level, at the level of the tissue, you have the X-rays, you have the CTs. For example, your low dose CT for the lung, which we use, the PET for all the follow-ups, then the MRIs. Then the molecular imaging techniques at the level of the include your multi-slide CT, the PET, again your MRA, the DOT, that is your diffuse optical tomography, then fluorescence mediated tomography, LNE MRIs, and your multiphoton microscopy, where they at the level of the cell and in a much greater detail, the tumor cells can be explored. Coming back to a very important word and a very important terminology here is your molecular biomarkers. What exactly are these molecular biomarker. For example, if you really recollect our decision, our basics in cancer biology, everything we are focusing on a single cell. For example, we said that there is a change in a mutation in the single cell level. Yes, that will lead to the cancer. We were really talking about how all the minute changes, so many of other, we were talking about how the hallmarks of cancer, it's not necessarily we said that a single hallmark will play a role will in the outcome of that particular transformation of a cell to a cancerous cell. No, it's like could be a coordination of the hallmark of events, or maybe a single one. Like that, exactly. Now can you come to a very good terminology, something which should be a favorite term for this whole course, should be your molecular biomarkers, or molecular cancer biomarkers. They are nothing but the molecular indicators which are measurable for the risk of cancer, or for the occurrence of cancer, or for the prognosis, or whatever we were discussing before. These markers are usually germline or somatic genetic variants, or they are epigenetic signatures, or they could even be your transcriptional changes, and very importantly your proteomic changes. Get back to your basics of cancer, where we were talking about from DNA to RNA, RNA to protein. In this, all this particular variants or the signatures, all these changes, we can be assigning it as the molecular signatures. These biomolecular indicators, they are mostly based on your you need your complete whole in nucleic acid, like such as your nucleic acids, your DNA and the RNA, and you need your proteins, and sometimes these are usually directly taken from your tissue samples. For example, from the tissue itself, directly you extract the RNA or the DNA, or then you can even take much easily from your blood. It's like your ctDNA, or from the saliva, or the buccal swabs, or the stool urine. This is all like absolutely first thing, whenever for all these molecular biomarkers and all, ideally it will be very nice if the minimum there is minimal invasion. It is like that is how where the whole diagnostics in precision oncology is moving towards, to we have a less invasive route for taking out the sample for use of molecular diagnostics. And many excellent is here is your detection technologies. You have wonderful techniques such as your NGS training, that is your next gen sequencing, and then and then methods to study your circulating tumor DNA, okay, or RNA or exosomes. These are all you have very good detecting technologies. Some genetics mutations, they increase the risk for developing cancer. That is like, for example, a genetic mutation. It could be like, if you take it as a biomarker, it is said to predispose us to cancer. For example, your BRCA1 and the BRCA2 gene, there is like, suppose this these genes are associated with an increased risk of cancer. So harmful mutations these genes can increase the chance of developing of breast cancer. People with this mutations can obtain more frequent sequence, that they may detect cancer in its early stages, and which can be easily treated. Please come back to this slide. It's molecular diagnostics in oncology, which we just grazed upon it in the last session as an introductory slide to coming to the molecular diagnostics in cancer. So I have used it. Just to come back here, you have like different assays being developed, which were already like for the recurrent mutations, where you use this PCR, then the single gene analysis, for you use the Sanger sequencing, and the multi-gene panels, you use the NGS, and then you use the whole exome genase. People for this hereditary cancer patients, so even this you use it in the risk for second malignancy. And then can we use this in the healthy people? Yes, maybe you can identify people for identification of subjects at risk. This predictive markers, for the predicting the cancer, can you have different markers, several assays, and this particular for that you use your DNA, RNA, proteins, and then cells, your tissue slices, and then for the molecular targets you have the HER2, EGFR mutation, BRAF, ALK, and ROS. For the Tumor prototype, you have even the importantly the mutation phenotype, sorry, tumor phenotype, you have the mutation burden. These are also very important circulating tumor fragments to assess, like different assays are there which with your CTCs, then ctDNA, then with the RNA and the proteins. For them, can they be monitoring of tumor burden, and the choice of therapy can also be uh, chosen here. For many carcinomas of unknown origin also, you have certain tissue specific markers, tumor specific markers with your point mutations, gene rearrangements and copy number variations. With all this, these are all the very important terminology for molecular diagnostics in oncology. For what are the current high throughput tests for cancer diagnosis? You have the for the micro RNA and the RNA, you have the microarray technology. For the SNPs, that is your single nucleotide polymorphisms, gene arrangements, there is the capillary electrophoresis. Then you have the MALDI TOF-MS, the sequenom for SNP genotyping. Then you have the pyrosequencing for your methylation analysis. And then for the breast, you have, this is where not only this, you even have the nanostring panels now, for the breast cancer. Then hotspot cancer mutations, there is this AmpliSeq, and then for this Afirma gene profiling, and then sequencing NGS. This is, you have the fantastic Illumina platforms. So there are much of high throughput now available for all the diagnostic cancer or cancer detection, not only in a very broader level, but very much till the cellular, till the mutation level. Yes, there is a way. Now we've really seen how do you, so this is one example, how I want to really highlight how different patients with the different biomarkers and with the different treatment strategies, how are they going forward. This is like biomolecular signatures. You can classify patients into new specific taxa. Isn't it interesting? Even though patients come with the same signs and same symptoms of cancer, but their outcome of the disease, even to the same therapy, is entirely different. This is a group of patients, where, for example, they have the biomarkers A and B, and then C. Now you stratify here patients with high A and B but low C here, but patients with low A, B but high C here. These patients have they could have a worse prognosis, but they benefit from treatment. This is the subclass of patients. Here subclass of patients, these patients could have better prognosis, but they also benefit from the treatment. You are able to stratify patients or classify patients according to the presence of the biomarker, and you are able to predict if to their outcome for the particular drug response. What are the novel biomarkers here? This is another fantastic table, This one more very interesting term which we will use is druggable targets. What is a druggable target? Where you have a small drug, small molecule inhibitors, which can act as drugs into the against this target. This every day this repertoire of targeted therapies is very much expanding for each particular cancer type. For example, your FLT3, NPM1, your SEB, CEBPA, and your PRAM1 in your ALL, These are all the very important markers for the leukemia. For all this AML panels, these are all very important markers. Your BCR, for example, your BCR ABL will serve as a diagnostic marker. Many studies, we'll be discussing in detail, like your ALK, BRAF, KRAS, EGFR. For the lung cancer. These are all very much like, for us now, what do we do here for EGFR? You need your DNA. Once you get your FFP from the pathology department, you take the FFPE, then you extract. This is FFPE is like a wax. In the wax, just imagine for a lung cancer patient, you really won't be having loads of biopsy tissue, right? It's not like a tissue where you can take and the tissue regenerates itself. It's a very small speck of biology. You have very fantastic diagnostic kits where your extraction of RNA and DNA from this FFPE samples is very well, the yield is very high and it's very good, quality is very good. After you extract the DNA and the RNA, you set it for the qPCR and you look for the panel of EGFR panels, that is a gene specific for EGFR. Then based on that, the clinician will be informed. They will be asking the report which is positive, is a negative. Based on that, he will be having the L-naughttip and the gefritip, which are nothing but your TKI inhibitors. For the melanomas, we have the BRAF, and for which the vemurafenib is the drug. These have very good consequences, in the therapeutic, all these particular molecular markers, biomarkers, they are having very good consequences in the for the therapeutic management of this cancer people. They have been approved. Many of these markers are very well approved by the world organizations. They are like all this particular cancer, National Cancer Institute, wherever, it's a must that people have to come with this particular signature biomarkers after detecting this particular cancer. Then for the colon cancer also, they go for the wild type RAS, the mutations. Then for the head and neck, yes, some people go for the HPV virus or other markers. Then for your breast cancer, as I mentioned, you have the ERB2, BB2. Then this goes for the targeted therapy. For the leukemia, you have the BCR-ABL panel. You have the different molecular diagnostic markers for various breast cancer types. Coming to the cancer detection methods for cancer types, at first we will come across with the breast cancer screening. This is how many of the mammograms are all there. So where there is where first the mammography is done, that is now very much of an important diagnostic tool, or CBE, that is your clinical breast examination by a healthcare provider, and the breast self-examination. They have been educated for early detection of breast cancer. Many before years, we have even the ultrasound, there is a magnetic MRI, and they have been added to the proposed list of screening modalities for breast cancer. Many studies after this, going through several screening, there is like they have many studies, they have come to the consensus that the women for aged between 40 to 75 years of if they are screened, there is a reduction in the relative risk of breast cancer death by 10 to 25%. The risk benefit ratio is more favorable for women aged between 60 to 69 years versus to 50 to 55 years. Here the mammography can also be is supposed to be operator dependent. Yes, you need to have a technician with it, and then it has to be and it can be done even in very high volume centers. At the molecular level, breast cancer is a very heterogeneous disease. When you say at a molecular level, yes, just imagine a breast cancer tissue. Can it be uniform? If I take 10 people, 10 women breast cancer tissue, is it uniform? No, it is not uniform. It is called heterogeneous, and progresses from alterations that take place in the gene that govern your cell growth, proliferation, and differentiation. All these genes, if there is alteration, then there is a progression towards breast cancer. Just here for the breast cancer, it is usually a gene or protein that is based on its presence or expression at a certain level, and it can predict the particular response. Here in this particular invasive breast cancer, that is your receptor estrogen or the progesterone expression is a powerful predictive marker for response to your tamoxifen. Recollect my first slide in the initial session, and then where we were talking, yes, can these genes can be the predictive marker for response to this particular tamoxifen, that is a drug. While the presence of HER2 amplification or overexpression, it predicts response to specific anti-HER2 or antibodies such as your trastuzumab, and also it indicates an enhanced sensitivity for anthracycline based chemotherapy regimens specific for breast cancer. This is again, I do not want to go back to our hallmarks of cancer or the basics, if you recollect, we were talking about all this particular pathways, for example, your RAS, how is it important, yeah, how is this particular signaling pathways, how are they important for during for a normal homeostasis or survival of the cell. But for example, if there is any alteration in this particular pathways, there is increase in cell proliferation, protein synthesis, angiogenesis, which are nothing but your hallmarks of cancer. This is a particular pathway. Here, this is like the important pathways, molecular markers for breast cancer, which are routinely used are your ER, PR, and your HER2. This is like, these markers along with your clinicopathological prognostic parameters such as the age, age at diagnostics, and the lymph node status, where recollect what we were talking in the last class, the tumor size, and then your histopathological grading. They provide the prediction for the prognosis of cancer recurrence after initial remedial treatment. Maybe can they be like whatever all this particular parameters taken together, they can really predict the outcome or future outcome of the disease, or maybe even any future appropriate treatment. This hormone receptors and this they are the HER2, they are the molecular markers, and they are of prime very much prime therapeutic importance. ERs and PRs, they are basically your proteinaceous markers, and they are usually found on the mammary cells, and then these usually stimulated by the circulated ovary hormones such as your estrogen and the progesterone. Both these hormones are vital for several functional events in the females, which as we know how important are all the estrogen and the progesterone. Breast cancer cells with these receptors, they receive signals from relative hormones they to grow like normal cells do, but these are already cancer. But these cells are also these are already cancerous due to DNA damage. These cells, they grow all the more rapidly in an undisciplined manner. Here the ER/PR receptors, then you have the HER2 receptors, which are detected by IHC, your immunohistochemistry, or by the FISH method. Then if they are positive, they respond to hormone therapy. If they are negative, if this particular receptors, they have to go for a different route therapies other than the hormones. The similar with your HER2 also, they respond to the monoclonal antibodies if they are positive, and then again if it's negative, they have to approach for different other targeted therapy. So colorectal cancer, which we have been studying about before also, which involves like for screening for this cancer, it involves either stool testing for occult blood, or for DNA associated with polyps or cancer, or structural examination, with looking for polyps or some early cancers. Screening was with the rigid sigmoidoscope, which from the before the late 1960s. That is like, and then even there is something like to examine the colon cancer, there is something what they call developed a barium anemia also. This is like how again get back to my basics of cancer again, how the normal mucositis, like how is the mutation, like for example you have your beta catenin APC, then the ENT activation, and then in the next step you have the a small aberrant crypt proliferation, early adenoma it happens, and this is where the at this stage you have the KRAS mutation, and that will lead, and then as further on, in the at the staging of the intermediate adenoma, you have the SMAD24 and the loss of heterogeneity. This is like how, and then you have the dysplasia adenoma, and then at the mutation at the TP53, thereby leading to a carcinoma. This is a very important model for adenocarcinoma sequence model for chromosomal instability. You have the CIN in colorectal cancer. This may be a very much a simplified model. Of course, it's not just a single genetic abnormalities for the for this particular progression, but but it's a very unstable chromosome leading to the colorectal cancer. As I said, you have the loss of the APC. First you recollect, right? We just discussed in the basics where how loss of this particular APC will lead to the complete carcinoma. Larger adenomas and early carcinomas acquire mutations in your GTPs, like slowly here you have the KRAS, follow with the loss of your chromosome 18q with your SMAD4. Sometimes even in the mutation in BRVAF, which is common in MS1 plus C colorectal cancer, are also likely to occur in the place of your KRAS mutations. Mismatch repair deficiencies, in sporadic CRC occur predominantly by downregulation of your MHC1, MLH1 through promoter methylation. This is the story about the colorectal cancer. Now coming to a very important cervical cancer screening, we've been discussing, very well much in the last session, how the government different policies for cervical cancer. We were talking about how the presence of an HPV could be a prelude for cervical cancer. So, cervical cancer, for example, if you all think about cervical, any cancer biologist, the first thing which will come to our mind is your HeLa cells. Henriette Lev, which is like she was a cervical cancer patient, and from her there the HeLa cell line was derived. So, these cell lines are nothing but from her own cervical cancer tissue, and then from there the cells were propagated in the lab until now. Several labs or several students are utilizing this particular cell lines as a model for cervical cancer. So, how do we, as the first model for cervical cancer screening, the pap smear, which was first developed by George Papanicolaou in the early 1940s. It was not even, it wasn't even introduced like a prospective randomized clinical trial, and it has not been much evolved from the initial time. So, like if you really recollect, this is how the normal LSIL, HSIL, then to the cervical cancer. This the original pap smear used an ectocervical spatula to apply a specimen to a glass slide. After then, the smear was fixed, stained and manually examined under this microscope, and as a result now also it is being used very widely. But we have a little bit a variation with the liquid based thin layer system. And then whatever this microscopy now, because this pap smear you really require only a pathologist to grade it. Now there is some much of AI coming in place. The slide grading also is happening via the AI based approach. The mortality is, but PAP has served us very well by reducing the mortality rates and bringing the and able to and has been able to show reduction in the cervical cancer incidence and mortalities after using the PAP smear. with the pap smear. This particular particular smear is very pap smear is very crucial for cervical cancer screening, and many women at the over the age of 40 are recommended to undertake pap smear testing. Biopsy samples are checked by the pathologist for your cervical intraepithelial neoplasia, that is carcinoma, that is your CIN. It's like it is a term used to describe CIN used to describe abnormal cervical cells that were found on the surface of the cells, usually after a biopsy. Usually CIN is usually graded from 1 to 3. Based on how abnormal the cells look under a microscope and how much of the cervical tissue is affected. Usually LSIL here, whatever you see here are usually generally SIN1. So HSIL changes seen are usually CIN2 or CIN3 here. One more important tool is like for screening of cervical cancer is your colposcopy, where a speculum is used to gently open the vagina and see the cervix. So, and the white vinegar solution is applied to the cervix to or acetic acid to show abnormal areas. Then this is like if there is CIN or 2 or anything, usually it is turns white. This is like this is about colposcopy. It's cervical bioscopy, where it's a small biopsy procedure is used to remove cervical cells or tissue to be checked under the microscope, like for abnormal cervical cells including your cancer. Coming to the pap smear versus HPV testing, this is something which is now like again, this is the cervical cancer screening is a very good example of how from the traditional methods, how it has slowly evolved into a molecular testing. Your HPV testing is for using molecular testing, and many companies have come up with many kits for detection of HPV in cervical scrapes. It's just nothing, you just boil your cervical cells for DNA, and that DNA either can be done using a PCR or a qPCR. You can look for the presence of HPV. On the field, yes, HPV testing it can be done. You have several many companies coming up with handheld devices. You may not have a very sophisticated instrument going on to the field. You would really need to have something on the spot. At least you screen 100 women, and out of which you say you test one of them positive via this HPV testing. Yes, they can go forward for follow up. You can basically by easing the test facility, or by making the test sample collection simple, or a point of care or on the field device, you can really have more participation or more recruitment of individuals into the screening programs. This is like, as we all know, that HPV 16 and 18, they are the cause for 70% of cervical cancer, and there are many other 13 other HPV known subtypes. This is the fantastic platform which is developed by the Cobas, the Roche, and that is the 4800, and where HPV testing can be used along with cytology co-testing, or it can be used as an standalone test for detection of HPV virus, which could be a prelude to cervical cancer. Before cervical cancer. Now this, like, this is like it's usual, it is and HPV testing is very well accepted or very well useful because of its negative predictive value. These are the recommendations for women at risk, like this, like screening for cervical cancer. This is usually begin at 21 years of age. Age 21 should can receive cytology screening with other conventional cytology smears or liquid based cytology. They should go for every 3 years. For women aged 30 to 65 years, the preferred approach to be screen every 5 years for both HPV testing and cytology. Cytology. Women who have undergone hysterectomy, they can need not go through uh, this particular cervical cancer screening. Coming for one more complex cancer screening, for cancer is lung cancer. First thing, earlier we only used to associate smoking and lung cancer together. Only people who smoke who have lung cancer. No, it is not like that. Lung cancer is now the leading cause of cancer. It is even taking the higher roads, much crossing the breast and the cervical cancer, especially in women in the premenopause age. So now definitely having a very good diagnostic test or a screening device or a screening tool for lung cancer is absolutely the need of an hour now. First thing, what are the different ways of screening? Definitely a direct symptoms, like your direct tumor infiltration, like include your cough with blood, wheezing, shortness of breath, and the biggest problem here with the lung cancer is most patients present themselves at stage 4. They are mostly confused with pneumonia like symptoms or with tuberculosis, and by the time the patient come to the hospital itself, it's like it is a very tough challenge for the clinician to answer this. What is the important tool? So, chest CT is a fundamental imaging tool for the evaluation of lung cancer, and it's most commonly used as a non-invasive modality for screening and staging of lung cancer. It is usually used to define the size, location, and characterize your lung lesions. Then from September from 2019, low dose chest CT it is employed for the screening of lung cancer in many in many of the high risk individuals in many countries. All the western countries are employing LDCT for detection of your lung cancer. Then you have the PET CT where uptake of the radio labeled glucose analog. You have different biopsies available for lung cancer. It's very important, It is like your fiber optic bronchoscopy. These are all the high end biopsies, because it's a lung is a very vital organ, and you just can't have like the breast or cervix and all, you just can't have a lot of tissue coming out. The patient, in case if any of these procedures are not taken care in the presence of an anesthetician and in the presence of a proper clinician, there are chances that the patients may collapse during the biopsies. Fiber optic bronchoscopy, where yes, it is like the bronchial pathway to this particular to the target lesion, where the sampling to be where the sample has to be performed using FOFF should be where exactly it has to be determined. It has to be precisely located by the carefully by the looking at the patient's anatomy before FBS procedure. It's very important. This diameter for this commercial FBS is usually around 6 mm. And EBUS is TBNA, which is nothing but your endobronchial ultrasound guided transbronchial needle aspiration. Now coming back to our fantastic slide here for the lung cancer, which we've been talking all throughout for many times, all throughout. For what exactly are these particulars? In all our hospitals, we go for this particular molecular markers. You go for the EGFR panels, you have the ALK panels, and not all hospitals have the BRAF, and not all scenarios go for the PD1 and the PDL1 expression. For the EGFR, you have it is very well mutation is very more prevalent in around 20 to 50% in adenocarcinoma, LUAD cases, lung cancer, adenocarcinoma. And the most common mutations in the EGFR is like your exon 19 deletion and the L858R substitution. So many people, many of us usually detect the EGFR mutations mostly by RT-PCR, which is something which is very easy. It's very quite cost effective, and then people even go for your Sanger sequencing and the NGS. You have the different drugs. Very importantly, this is a very good example of how the tailoring of the cancer treatment goes on. So you have a positive in this particular mutations. Yes, you have this particular drugs being given, like your gefitinib, efitinib, erlotinib, all this are being given. Then again, and this is again taken from your DNA from the FFPE. Please recollect our earlier slide. And then you have the ALK, where it is present in 3 to 5% in non-squamous cell lung cancer patients, and then among which your EML4 ALK fusions are more common. And then the most popular method is you even have the RT-PCR here, then you even have the FISH, FDA approved FISH by IHC, which is done. These are all very approved tests, and then even the NGS. Then the ROS is also prevalent in 2 to 3% of your adenocarcinoma patient, and this particular mutations are common. And then apart from your RT-PCR, you even have your IHC and the NHC. This again, different drugs are available for the BRAF also, and then the PD-1 and the PD-L1 expression, these are also now gaining lot of popularity after for uh, the treatment. And then there are prevalent in 42% of the lung cancer patient, and then for them they have the different drugs. So, diagnosis of coming to this concluding, now this particular in this whole both the sessions in the last session and now we have really understood what are the different, why do we really go for cancer screening, what exactly, other than eliminating positive and negative. And then and we have really gone into the in-depth studies of what exactly are biomarkers, and how do we really, what exactly the tissue samples or the samples required in the laboratory for screening for this particular biomarker. No longer cancer is diagnosed as only on morphological parameters, as I said. So it is that you need to have your algorithms which is supported both by your IHCs, then your DNA signatures, the mRNA and the miRNA and the proteome signatures. All of them are very important to have to stratify the cancer types. Though many multiple platforms, high throughput technologies which are enabling better analysis, still, we are it is not like tumors are characterized by a single gene alteration. You are having a signature genomic alterations, as I mentioned here, EGFR signature genomic alteration for lung cancer. The ultimate goal of your cancer diagnosis should be for personalized medicine, to identify and grade and do a perfect diagnostics and give a guided therapy, so that every patient receives the prediction, the medicine which is in the right dose and in the right concentration, and then they will be able to predict, is this going to really help the patient in the better outcome. Thank you.